We are very happy to welcome Professor Alain Brunet tonight. He is from the Department of Psychiatry of the McGill University in Montreal, Canada. Now, he explained to me before that he is a scientist practitioner, and he is basically carrying 3 hats at various times, I suppose. He works as a researcher, he also works as a teacher, and he also works as a therapist. So he's going to talk to us about Reconsolidation Therapy. And I'm really, really looking forward to hearing more about what this is. So I'd like to hand over to you, Alain, and let's get started. Thank you.
Thank you very much, Christophe. I would like to warmly thank CoCreate Humanity for giving me this opportunity to present my work and hopefully to disseminate it and make people benefit from it. I am a scientist, and I've been very interested by the problem of post-traumatic stress disorder. I've devoted my career to studying post-traumatic stress disorder, and I will be sharing with you some of the discoveries that I have made over the years as a scientist practitioner. So I've prepared a slide deck that I'm going to share with you. Can you see my slides? Yes.
Yes, we can.
Well, first of all, I would like to again mention the great work of CoCreate Humanity. They've really made a very nice advertisement for this webinar. It's really awesome. So yeah, so we're going to spend 2 hours together, and we're going to cover essentially 3 elements. I think that essentially we want, you want to know, and I will be presenting a theory of illness, current treatments about this illness, and a theory of healing or recovery. I'm putting the word illness in quotation mark, of course, because I think that PTSD is really, PTSD or post-traumatic stress disorder is really much more like an injury than an illness. But this is how it is conceptualized in psychiatry. Mental disorders are conceptualized as disorders or disease or illness, which I think is not the best metaphor, but I will use those terms interchangeably, although I acknowledge that they're not necessarily your typical illness. So essentially, I'm going to be giving you a short presentation about how PTSD develops, and of course, it's you'll see it's in science we like to use heuristics. So it's kind of a simplification, if you like. I'm also aware that PTSD can be much more complex than that, but it's part of our job in science to try to create models, fairly simple models, and then from those models we can develop theories of treatment. And so we'll be also going over the main treatments for PTSD. What are they currently? We'll see that they're essentially psychotherapy or medication. And then in the third part of my talk, I'll be presenting the discovery of reconsolidation theory, and then I'll be presenting some of my work which evolved from that theory and which became Reconsolidation Therapy. Reconsolidation Therapy is an innovative treatment that, excuse me, I've been teaching to hundreds of therapists since 2018. And my goal by teaching this new therapy is to really make a dent in the rate of PTSD worldwide. I think that PTSD is more treatable than we used to think. There are effective treatments to treat PTSD, reconsolidation therapy being one of them. It's one treatment that I'm particularly fond of, particularly proud of in terms of what it accomplishes. But of course, there are other treatments, and when it comes to treatments for PTSD, we should avoid the idea of one size fits all, and we should acknowledge that there are many ways to recovery, and that's the way it is. And so that will be the first hour of that we'll spend together. Maybe 50 minutes or so will be devoted to those three elements. Then we'll be taking a short break, and after that there will be a discussion period. So sometimes people ask me, should I wait for my questions? Should I ask my questions immediately? Should I keep them for later? I guess the answer to that is that if you need to ask a clarification question, you should ask it immediately as it springs to mind. If you want to engage in a debate, or if you have ideas that you'd like to pass by me or to discuss, that should be kept for later. Okay. Now I'm going to try to slightly move my camera so that I will be speaking to you more directly. Okay. So just bear with me for a minute. The image might move a little bit, but I just want to make sure that this is optimal and most comfortable. Okay. Okay, that's better. Good. So very briefly about me, you might be wondering about my credential, what have I done, where I come from. So very briefly, I just want to mention that I've been teaching at the Psychiatry department of McGill University for the last 20 years. I'm not a psychiatrist, however. There's a lot of us psychologists at the Department of Psychiatry conducting research, and we have a very comfortable and fruitful collaboration with our fellow psychiatrists. I'm also the former vice president of the International Society for Traumatic Stress Studies, which is probably the main body, the main international body, which federates scientists, practitioners interested in the field of traumatic stress. I'm also the former editor of the flagship journal of the ISTSS, the Journal of Traumatic Stress. I've been one of the co-editors of that scientific journal for almost 7 years. I'm also a member of the Canadian Academy of Health Science and founder of the Reconsolidation Therapy. Okay, I'd like to ask a question. Anybody recognizes this painting on the right? Yes. So how many recognizes it? You can either raise your hand or your finger if you prefer, if it's easy. Yeah, okay. So a number of people recognize that painting. My next question is this. Do you know why I am showing you this painting as part of my talk today. No. Yeah. The Medusa is a character from antiquity, a mythic character from antiquity. And you probably recall from when you were in high school or perhaps at university that if a warrior looked at the gaze of the Medusa, this person would be transformed into stone. Okay. And in this painting, you also remember that Medusa, the hair of Medusa were made of snakes. And so this is the head of Medusa. And at the same time, what you can see in this face and in this set of eyes is fright. And fright is a very central experience of traumatic stress. And when the warriors would cross the eyes of Medusa, they would be transformed into stone. And that's an illustration for many of us that in antiquity, people knew already about traumatic stress. And traumatic stress has been with us and around us for centuries. It's a very profound and old, humane experience that's been around us since the dawn of humanity. And it's only recently that we've made astounding progress in the treatment of post-traumatic, what we came to call now post-traumatic stress disorder. So I just wanted to share with you this appreciation for art and for the people who came before us and who already knew about traumatic stress. So traumatic stress is not a new invention, although it has only been acknowledged in major psychiatric nosologies like the DSM in 1980. So I'm going to present to you a very simple theory of trauma. And as I go about doing that, I'll be introducing to you familiar faces like Pavlov, Skinner, and I'll be taking an example of a car accident, because a car accident is not can be a traumatic event, yet at the same time it's not it's easy to describe, and most everybody can relate to that without becoming too emotional at the same time. So I'd like you to imagine that you are, so the first part is of traumatic stress has to do with the event, okay? And the event, the traumatic event, is a special form of fear conditioning, of classical conditioning. And classical conditioning was discovered by the famous Ivan Pavlov. And so I'm going to tell you a little bit about Pavlov and what he found, and I'm going to relate that to PTSD and traumatic stress. So you all know about the story of Pavlov's dog and how his dogs became conditioned every time Pavlov would, Pavlov's assistant would go to feed his dogs. For some reason or other, a little bell would ring. And so after a while, the dogs became classically conditioned. They were conditioned to being fed a few moments after hearing the bell. So Pavlov noticed that when the bell rang, the dogs started to salivate. And Pavlov was so intrigued by this phenomenon that he actually abandoned what he was in the process of studying. You know, he was very interested in digestion and things like that. And he was so intrigued and fascinated by what he found, and he thought that it was so important that he abandoned everything that he was doing to study dogs salivating. Now, I don't know about you, but me, I would have probably not abandoned everything that I was doing. And I think that's really the hallmark of a genius. So what's the relationship between PTSD and Ivan Pavlov, you might say? Well, picture this. Imagine that you are in a car on the highway and the weather is not good. Maybe the weather is, around zero, and, there's a rain, and then, it's half rain, half snow. It's very slippery. It's all gray. It's the end of the day. And then there is a red truck in front of you. And all of a sudden, this red truck puts on the brakes very abruptly. And you're following that truck. And then, boom, you hit that truck. And you have a big car accident with that truck. And as you hit the truck, you can hear the brakes that are being put on abruptly. And then you might even smell in the few seconds later the odor of burnt rubber. And you will also hear a sound of crushing metal. Now, all these things, the color red, the sound of crushing metal, the burnt rubber, the fact that it's raining and that you're driving on the highway, all these things, from now on, they have been burned into your brain, and you have been classically conditioned. What does that mean? That means that after this car accident, every time you smell burnt rubber, what are you going to think about? Your car accident. Every time you hear a metallic noise, what are you going to think about? Your car accident. Okay? And that's just the normal way our brain function. Okay? So this is an instance of classical conditioning, and it's been imprinted in what we would say a single instance, a single trial. With respect to Pavlov's dog, he had to ring the bell and present the food, ring the bell, present the food several times before the association between the bell and the food was created. But in traumatic stress, this occurs in a single instance. And you might be interested in psychoanalysis. You might be interested in EMDR. You might think, well, PTSD is much more complex than that, and so on and so on. And, I can agree with you. But I think that we will also have to agree that in traumatic stress occurs classical conditioning. And this is ubiquitous. This is a ubiquitous phenomenon. And the net effect of this is that every time you will be exposed to a trauma reminder, it will elicit painful memories, painful and dysphoric memories that will come and disrupt what you were currently engaged in. Okay? That's just the way it is. That's just the way our brain works. And this is how we are wired. Okay. Now, so far, so good. But you might tell me, well, Professor Brunet, intrusive recollections are just one small part of PTSD symptoms. What do you make of all the other symptoms? Well, here's how we can explain the other symptoms. We all agree that, when people are confronted with trauma reminders, and they unwillingly think about their trauma, this is something which is dysphoric. This is something that people try to avoid, because we're always engaged, we're constantly engaged in what I would call self-regulation, okay? We're always regulating ourselves, regulating our mood, how we're doing, how we're feeling, okay? This is something which is ongoing at all times, okay? And when we've had a bad day, you know, we might have a glass of wine or a drink. Well, this is a way of you know, self-regulating. If we've had a long day and we're stressed and we want to go jogging, this is also a way of self-regulating. Or if we had an argument with someone and you know, we go into our room and just stay calm, this is a way of self-regulating. Okay, so we're always engaged in self-regulation. And when trauma reminders you know, become present, we need to self-regulate. And so what is the main strategy that people suffering from PTSD use to self-regulate? Well, essentially, they avoid trauma reminders. And why would that be a good idea? Well, I don't know if it's a good idea, but it's certainly what a lot of people do. And in essence, the idea is that if I avoid taking my car, if I avoid going on the highway when it rains, or and so on, if I avoid trauma reminders, I will be rewarded by not experiencing those painful memories. And that's why we typically say, and that's why therapists pay a lot of attention to what we call avoidance symptoms, okay? Now, it turns out that avoidance symptoms has some benefits on the short run, but on the long run, avoidance symptoms are what we call maintenance factors. Imagine that you just fell off a horse. What does the saying say? The saying says, if you've fallen off a horse, the sooner you get back on that horse, the better. Why does that saying say that? Well, I think we all intuitively understand that if we've fallen off a horse, if we get back immediately on the horse, we will not stay with this idea that horses are dangerous, okay? But until you've gotten back on the back of that horse, you will remain with that memory. You will remain with that impression, with that perception that horses are to be feared, okay? So unless you confront your fear, and the sooner the better, of course, in a certain manner, you could just, you know, there are ways of doing this, but as the sooner you confront your fear in a safe context, the better, and the faster you will recover, I would say. Okay, so that's why in nearly every effective psychotherapy, we need to talk about our traumatic event, or we need to confront ourselves with our traumatic event, and it's part of every effective treatment modality. Okay. And so we also mention sometimes that people who suffer from anxiety disorders like PTSD or other anxiety disorders will go on adopting certain behaviors that bring relief in the short run. And sometimes we will say that there is a cognitive error. And let me give you an example of a cognitive error. So it's embodied in that little joke. Someone says, "Why do you have a banana in your ear?" Well, it's to keep the elephants away. But there are no elephants here. Effective, eh? So this is just a silly joke to explain to you how sometimes we will go on doing something because we think that it will bring relief, until we find out, until we realize that there's no need for us to do that, okay? So that's an example of avoidance behavior. Now, so how do people, how do therapists deal with avoidance behavior? Well, by now you should understand with the horse example that the idea is to confront our fears. And what happens when we confront our fears? Well, Pavlov said that it led to extinction of the fearful behavior, okay? So extinction is the therapeutic ingredient which is involved in nearly every effective psychotherapy for post-traumatic stress disorder, okay? Including talk therapies, cognitive behavior therapies, and even EMDR, okay? So extinction is the therapeutic ingredient. And in the case of Pavlov's dog, if you wanted to extinguish the salivating response, what would you do? Well, you would start ringing that bell at times when it does not predict the occurrence of food, right? So you would expose the dog to the bell ringing, but you would withhold the consequence, which was food, okay? And so you would present the bell again and again and again until the dog stops salivating, which means that the behavior has become extinct, okay? Now, I hope I've managed to walk you through, the most famous and important behavior theories and behavior modification theories of the past century. We've come a long way, and we've treated a lot of disorders with that. But so where am I? Yeah, okay. So let's talk about the limits of such treatment. So here are the limits of such treatment. Let's say that you are engaged in EMDR or CBT, or even talk therapy. You go and talk to a therapist every week about trauma. For a century or so, there has been a debate as to the fate of memories that have been extinguished. So in other words, if I associate A and B, if there's a kind of link or bond that is created in my mind between A and B, okay? If I've created an association, if I've created a conditioned response, and then I undo that conditioned response, am I really undoing and removing the link between A and B? In other words, if I had taught a dog to salivate at the sound of a bell, and then I had presented the bell again and again and again at times when there is no food, is that dog just like a naive dog who has never been trained? And there was a long debate. There was perhaps a 100-year debate about that, whether if you extinguish a previously learned material, does it still exist in the brain? Is there still a relationship between those things? It turns out the answer is yes. There remains a relationship between those two elements. There remains an association. And it's like our memories are just like when you dig to our memories are just like historical moments that, if you dig deeper into the ground, you will find artifacts of the past. Okay, so it's just the same way. So so now that you understand how most therapies for PTSD work, you need to understand why, what is the limit to extinction-based therapies. Well, in essence, when you conduct psychotherapy using extinction-based approaches, you need to extinction must be as generic as possible. You know, if you were hit by a red truck, you should no longer be responsive to the color red, right? Because the color red is most everywhere. So you want to really create an extinction procedure that will not be only useful in the therapist's office, you know. But it turns out that it's kind of mission impossible in a sense. It's impossible to create a generic memory which will generalize to all the possible situations where you will be confronted with trauma reminders. So it's just a matter of time for that memory to eventually return and kind of erupt in your memory, okay? So it is understood that when you undergo cognitive behavior therapy, you will have, you will have relapse, okay? And that's a big problem in the field of psychotherapy. Okay, now I've presented to you a simple theory of traumatic stress, and I've begun talking to you about psychotherapy. Now let's review together very quickly what are the main approaches to the treatment of PTSD. Before we go there, I would like to just take a small detour and tell you a little anecdote. And I would like to take you back to the year 1952, when chlorpromazine was first discovered. Do some of you know about chlorpromazine? It's called also Largatil, and it was the first antipsychotic to be ever discovered. Like most treatments in psychiatry, it's a serendipitous finding, and it was the first chemotherapy, if you like, which led to deinstitutionalization. Okay, from then on, patients, we were able to patients were able to live outside of the asylum. And it turns out that this pharmaceutical company, Rhône-Poulenc, had developed a new class of medication. And 4560-RP was an antihistamine. So essentially a drug that is being used for allergies, to treat allergies, right? And it had an important side effect. It led to sedation. It had some pretty important sedation. And so it turned out not to be a very good anti-allergy medicine, but Rhône-Poulenc said to Henri Laborie one day, why don't you try that? And why don't you see what you can do with that? And Henri Laborie was very interested in sedation and states like that. And so he went to see his good friend, the psychiatrist Pierre Deniker at Sainte-Anne in France. And he said, you should try this medication with your agitated patients. And that's what Pierre Deniker did with Jean Delay. And it turned out that it was really the response to this drug seemed like wonder, seemed like magic. And for one day, 4560-RP would mask the symptoms of psychotic agitation. It would even reduce delusions and hallucinations. So it was just like considered like an amazing discovery, perhaps one of the most amazing discovery of the 20th century. And eventually, these folks received the Lasker Award, which is considered the small Nobel. But what does Heinz Lehmann has to do with that? Well, Heinz Lehmann was a German psychiatrist who immigrated in the 1930s to Canada. And he actually directed the hospital and research center where I work, the Douglas Institute. And he was the first to use antipsychotics in North America and to publish a paper about that. Now, this is an interesting anecdote, but there's another reason why I'm telling you about this. And the reason I'm telling you about this is, have you noticed that 70 years later, we're still treating patients the same way that we used to 70 years ago? What do I mean by that? I mean that we are giving, typically, when we're treating with pharmacotherapy, we're giving one pill a day to our patients to mask their symptoms, their psychiatric symptoms, and at the cost of serious side effects. And the next day, you repeat the treatment. And you know when you start, but you never know when you're going to stop. And so I've been throwing flowers at that treatment. Now I'd like to throw the stone. Unfortunately, we're still treating patients the same way 70 years later. We have not cured one single disorder in psychiatry. And this has led to a very beneficial economic model for pharmaceutical industries. And it's essentially giving one drug a day to prevent someone from being sick for the remainder of their lives. It's a palliative model. It's not a curative model. And while I realize how complicated it is to try to cure mental disorder, I'm at the same time that I'm impressed by the discovery of biological psychiatry, I'm also appalled that we're still treating patients 70 years later using the same model. So in a sense, you understand by now that there are essentially two ways of treating PTSD. The main treatment for PTSD is psychotherapy, and the other treatment is antidepressants. Now, the international guidelines no longer consider that the best SSRI, the best antidepressant medication for PTSD is paroxetine. Here locally, it's called the Paxil. In Europe, it has another name. I don't remember. But Paxil has been for a long time the recommended first-line treatment for PTSD. It no longer is. It's psychotherapy now, which is considered the main treatment. But Paxil is an effective medication. However, it's slightly superior to the placebo. However, you need to take it once a day, and it can lead to sexual problems, inability to achieve orgasm, and weight gain. So if you are a young person, let's say in your 20s, and you want to find a partner, a romantic partner, maybe you want to start a family or something, and you have gained 10 kilos and you cannot achieve orgasm, it's not ideal. So in many instances, people will abandon their medication. And especially in the first 2 months, there is a very high abandonment of the treatment. So in a sense, we can say that SSRIs are effective to treat PTSD, but on the other hand, we have to acknowledge that up to 1/3 of the newly treated people will abandon their medication within the first few months. So I said that. I said. Excuse me. I just want to. So abandonment of treatment is the major issue with medication. And then with respect to psychotherapy, we've seen that psychotherapy are effective for PTSD. About 2/3 of the patients benefit at the closure of treatment from psychotherapy. But 1 year later, we find that only 1/3 of patients benefit from psychotherapy because about half of them have relapsed. So we could say that the problem with psychotherapy as we know it is relapse. And the problem with medication as we currently know it is that people abandon their treatment. So that's kind of the state of affair, if you like, in the field of PTSD and in the treatment of PTSD. So far, so good. You're still with me? Yes? Okay. I've made myself clear. Do you have a question? Clarification? No? Okay. So now we're getting into the good stuff. We're getting into the discovery of reconsolidation. Okay. So reconsolidation. Reconsolidation was really discovered in 1968. This is the original paper, and it was written by Mezzanine, Miller, and Lewis. So so Lewis is the senior author. So if you're a little bit familiar with authorship in science, you know that this was the team of Lewis, and Mezzanine was probably, you know, the student or the postdoctoral fellow of Dr. Lewis. And essentially, this is the first discovery of reconsolidation, and it was conducted in rats. And this paper is called Retrograde Amnesia, produced by electroconvulsive shock after reactivation of a consolidated memory trace. Now, I might shock you a little bit, no pun intended. We're going to talk about electroconvulsive shock for a minute, or ECTs. We all know that ECTs have a terrible reputation. And I myself have always, you know, for a very long time, I've been really, I've been like everybody else, and I've been under the belief that it's a terrible treatment. But you have to keep in mind that this is a last resort treatment, which is being used with very often suicidal people suffering from major depression, for whom no other treatment has succeeded, and who are highly suicidal, who have very often made several attempts at suicide. And electroconvulsive therapy can be beneficial in such situations, and it can at times save lives. But why am I talking to you about electroconvulsive therapy? It's because Dr. Lewis was very interested in working models of memory. And he noticed one thing. He noticed that when you undergo ECTs, it's the more recent memories that go first. And you remember the older memories better than the more recently acquired memories. And then he figured it's as if memories could exist under two forms. One form would be very vulnerable and malleable. And the other one is like if it's been in storage and it's not prone to being interfered with. And so he began to develop this model where memories can exist in two states, you know, one which is vulnerable and the other invulnerable. And he actually created a very sophisticated experiment that I'm not gonna go over because it would be too long. So this experiment took place in 1968, and later on, reconsolidation was rediscovered in the late 90s. And this is when, you know, the more contemporary rediscovery of reconsolidation took place. And that was in the late 90s by the team of Siwiślewski and Sarah, a Polish and an American, both living in France. So what does this theory says? Well, this theory, this reconsolidation theory says this. It says that when you form a new memory, this memory needs to be saved to long-term memory storage. So you can take the metaphor of your computer. In your computer, you have ROM and RAM. So for older folks, ROM is like CD-ROM. Remember CD-ROM? CD-ROM was for storage, right? So RAM is the active memory, and ROM is the storage memory. Well, it turns out that our brain is just wired in a similar way, and that metaphor holds for us. So when you form a new memory, this memory needs to go from short-term memory to long-term memory. And that is a process, that is a basic neural process. And this process takes between 2 and 5 hours to be completed. Okay? And unless a memory is transferred from short to long-term memory storage, it will cease to exist. Okay? For instance, if I say 514-918-1822, you have no idea what this is about. Well, it turns out it's my phone number here in Montreal. Okay? You're probably going to be able to keep it in your short-term memory for a few minutes, but probably not more than that unless you rehearse it. Or unless I tell you very emotional, something very emotional, very important to you, then you are likely to transfer it to long-term memory storage, okay? So this is called consolidation, actually. And then when you recall a memory, it turns out that this memory comes back to the short-term memory storage. And the discovery of reconsolidation is that this memory needs to be saved again to long-term memory storage. You might tell me, well, Professor Brunet, this is really, this is a no-brainer, and this is just, why is this such an important discovery? It sounds so mundane, it's like nothing really. Well, it turns out that it makes a world of difference, a world of difference. And let me explain to you why. Imagine that once a memory is consolidated, we used to think that once a memory was consolidated into your brain, it was forever. In the late 90s, when I was a postdoctoral fellow, there was this theory circulating that traumatic memories are burnt into your brain, probably in your amygdala and your hippocampus, and they're burnt into your brain, and they are forever. And you can just not do anything about them. It turns out this theory was wrong. And when you recall a memory, the same way you can interfere with a new memory, you can interfere with the resaving of an old memory. I said earlier on, I gave you my phone number. Now, I've actually interfered with this memory by keeping, as I've been talking to you again and again, and you've been listening to me, so I've been monopolizing your attention. Your attentional resources have been geared toward me and not toward my phone number. And because of that, this memory has probably not been consolidated, okay? So there are two ways with which you can interfere with a memory consolidation or reconsolidation. One is by removing attentional resources from that memory. And the other one is pharmacologically. And that's when propranolol steps into the game. Propranolol, you've probably heard this if you Googled my work, if you Googled me, if you've heard about reconsolidation therapy, you know that this is a transdisciplinary treatment, which is which uses a medication. This medication is called propranolol, and it's a beta blocker, and it's commonly called a reconsolidation blocker. So what does it do? Well, if you recall a memory, if you form a new memory or you recall an old memory under propranolol, propranolol will interfere with the consolidation or the reconsolidation of that memory. And so reconsolidation is the discovery that memories need to be saved again to long-term memory storage to persist. It's that simple. The other thing, which is fortunate for us, is that the same way that we're able to interfere with memories in the process of being consolidated, we can also interfere with a recalled memory in the process of being reconsolidated. And that's the discovery of reconsolidation therapy. So this initial finding was discovered in animals, and then it was replicated in humans, in healthy participants. It was also replicated a number of times. There are meta-analyses that my team has conducted showing that this is a robust phenomenon that has been replicated countless times, okay? So now we have this model. This is really our model with which we're going to build to create a form of therapy. And you understand now the basic ingredients of that therapy are recall, okay, and interference of that recall with a reconsolidation blocker. So the therapy that my team developed consists in recalling a traumatic memory and then blocking its re-saving to long-term memory storage with a medication called propranolol. Because there are really two things that you can do when you recall a memory. Why does memory reconsolidation exist? It's a process, it's a memory process that we did not have a clue that it existed up until about 25 years ago. And reconsolidation is actually what evolution has given us to update our memories. So it's a quick memory update mechanism, which is different from a classical conditioning and operant conditioning by Pavlov, by Skinner, and and blocking reconsolidation doesn't call upon extinction mechanisms. They're entirely different mechanisms that achieve similar goals. Okay, so we really are confronted with a new mechanism for treating patients, which has several advantages. So reconsolidation therapy, I'm going to give you a very quick example of how it unfolds. I'm going to show you a little bit. I've been talking for an hour or so, so I'm almost done. So let me proceed. So in essence, in reconsolidation therapy, first we conduct an assessment to determine whether the patient suffers from PTSD and whether the patient can receive propranolol. If the patient can receive propranolol, well, if you're a psychiatrist, you can prescribe it immediately. If you're a psychologist like me, you send your patient to their general practitioner to receive a prescription of propranolol. Then on treatment session 1, you're going to ask your patient to write a trauma narrative. But first of all, they will have taken propranolol 1 hour earlier, okay? And then in subsequent treatments, this is really in a nutshell, it's actually much more sophisticated than that. But really just to give you, the flesh and bone description of the treatment, and during sessions 2 to 6, each session typically lasts 25 minutes. The patients are essentially going to take their medication and recall their traumatic event by doing an activity which sometimes will be reading their trauma narrative, or in other instances, we will do other things that are related to this trauma narrative. So reconsolidation therapy typically takes place in 6 sessions, 6 once-a-week sessions of about 25 minutes. because it's useless to conduct longer sessions. And those sessions essentially consist in recalling the traumatic material under the influence of the reconsolidation blocker propranolol. So this is an example of a trauma narrative, for instance. You will note that it's written in the first person present tense. It also involves a number of details. We consider that if there are lots of contextual details and physical sensations, we think that this is an optimal way of reactivating that memory. This is perhaps my most well-known piece of work. It was published in 2018 in the American Journal of Psychiatry, which is among the 2 or 3 best journals in psychiatry, certainly top tier. And so we published a randomized control trial in which people recall their traumatic event, either under propranolol or under placebo. And what you can see on the left panel, it's the intent to treat analysis. On the right panel, it's the per protocol analysis. And both analyses yielded a very similar figure. So the orange line are the participants who actively recalled with the help of a therapist their traumatic event, but under placebo. And the green line is the group who did that under propranolol and for whom reconsolidation was blocked. And what you can see is that there is a very important improvement. There's a decrease of about 25 points on the PCL score, for those of you who know that measure. And we also obtained decreases in the 2 types of analyses, and also on a clinician-administered scale called the CAPS. So we achieved to demonstrate efficacy of that treatment against the placebo. Several other studies have been conducted, which I will not present today. Now, this is pretty much what I had to present to you. I thank you for bearing with me for a good 1 hour. I know this is a fairly dense presentation, but I hope that I hope it got you excited about this treatment. You probably have a lot of questions by now. You're wondering about numerous things, perhaps. So as I understand it, and Hélène, if you want to take the lead here, perhaps it's best before we take a short break and resume.
Thanks a lot, Alain, for your presentation, and thanks everyone for your attention. Just to let you know that Professor Alain Brunet will do exactly the same session in French on Thursday, the 23rd of September. And as it is mentioned on the PowerPoint,